So at CareFirst, we're just getting started on this journey. This is a long-term journey. Just to put this in perspective, what we are setting out to do is change the economic dynamics of 20% of our economy. Did you know that 20% of the United States gross domestic product goes to healthcare? Nearly 20%. Last I saw it was 18.9%, but we can round up, right? So we're talking about a massive part of the United States economy, and it's not going to change overnight. It's going to take a lot of time. So our first steps here are these new value-based constructs. We are working with, partnering with large provider organizations, small provider organizations to focus on creation of value and outcomes, defining together what that is, defining together what problems we want to solve, thinking about how we get more equitable healthcare delivered both on a geographic basis and by population. These are important features of our value-based care programs. And today, all of these programs continue to operate on fee-for-service medicine. So we measure the result based on the outcomes that we see in all of the data and analytics. But it is still a fee-for-service system today. And because it's nearly 20% of the economy, and we're trying to change the economics of 20% of the economy, it's going to take a little while to shift that to new payment constructs. But what we're doing today is we're getting our provider partners comfortable with managing populations. And as they get better and better at it in this fee-for-service world, we will be able to move to even more innovative payment models in the future that get at complete redesign of the business model of many of our healthcare partners. So what you can look for in the coming years would be opportunities to move to new models that fund primary care in a different way that's not based on fee-for-service, that fund broader health systems in a different way that's not based on fee-for-service. It would be extremely predictable for employers. You would know what your expense is going to be for a particular population. There may be some things that are outliers that are provided for still in a fee-for-service, but the core of the cost would be more predictable on an annual basis. And then for particular types of encounters with the healthcare system, like a knee replacement, like a colonoscopy, like the birth of a child, we may pay one fixed price to the provider organization, again, offering more predictability for our employers. And the great thing for the provider is if they can predict and know what the cash flow is going to be, and it's not entirely dependent on the generation of volume, they can look for new economies to get the outcomes that we seek for a fixed amount of cost. There are many things that can be done to redesign the system if every increment of revenue for the healthcare delivery system is not based on a visit with a patient by a licensed physician. There are lots of opportunities under that umbrella to make things better using technology and employing different types of healthcare providers that are appropriate for different types of activities with patients. We can get further. We can get more value from the healthcare delivery system. We can achieve a place where we have more affordability that translates into more accessibility and definitely a more equitable healthcare system. There's an awful lot of funding going into healthcare today. If it was better allocated and was more focused on creation of value, we'll have a better healthcare delivery system to serve everyone.